Доброго дня, шановні колеги. Ви підключаєтеся до вебінару.
Dear colleagues, good afternoon. So you're about to join the webinar in conjunction with the partners, and now we are waiting for the other participants to join. So in a matter of a couple of minutes, we will make a start with the webinar.
Час 15 година, і ми будемо починати.
It is 3 p.m. and we will make a start. Once again, the words are welcome to you. So UPHC webinar here in conjunction with the counterparts, empiric treatment of by means of antimicrobials of the most widespread infectious diseases in the clinical practice, and it is a follow-up of the previous webinars, IPC, and also antimicrobial stewardship, so perspective for Ukraine. This series of webinars, so from 2023, and together with our partners and colleagues, so we carry on with those webinars, and we will do so furthermore. If you want to look up or to listen to the webinars of antimicrobial stewardship dedicated webinars, please join our YouTube UPHC channel to get to find out more, and lots of useful materials uploaded. And talking about the forthcoming plans, so we will carry more with the webinars to keep tuned, and please sign up and follow the UPHC Facebook channel, so we will have our timely uploads. And I would like to say thanks to our colleagues and counterparts, especially to the ICAP, Columbia University, and CDC and ACMED as well, because without them, so this score of webinars would have been short-lived. Thanks very much for your support, and thanks very much that they're sharing their valuable experience. And also the speaker and very distinguished lecturer of today is coming from ACMED. Therefore, talking about the logistics and housekeeping, so this lecture shall last for 1 hour, and after the lecture, so we will have a small session devoted to the questions and answers, so to be handled by the lecturer himself. And so please feel free to drop down your questions in writing to the chat, and we have simultaneous interpretation here to be able to listen to the Ukrainian interpretation. So the instruction is up on the screen. Please stay on the Ukrainian channel. So it is the globe icon. If it is the laptop, on the smartphone, it might be slightly different. choose Ukrainian language for interpretation simultaneous, and the webinar recording shall be uploaded soon. We won't mark time any longer, and I would like to introduce the keynote speaker of this afternoon. So, empirical antimicrobial treatment of the most widespread infections, and the speaker for this afternoon, Professor Nathan Peiffer-Smadja from the Paris-Cité University, and he is also the IPC, and he is also infectious disease physician in the University Clinic, Bichat, Paris, and also he is very much responsible and well-versed in antimicrobial stewardship, and he is ready to share his invaluable experience, tremendous experience. Also, the floor is all yours, Nathan.
Okay, thank you very much for this nice introduction, and thank you for inviting me. It's really an honor to be with you today and to do this webinar. So I'll present some advices on most common infections, and then at the end, do not hesitate to ask questions, because I think it's a discussion. Maybe I have things to share, but you also have specific expertise and probably things to share with us and to teach me. So thank you for this invitation. so I'm part of SGAP, which is the study group for antimicrobial stewardship, where I'm the education lead in the European Society. Next slide. I will talk about the 3 common infections, because I did not want to rush it and to try to do all the infections that are common in less than 1 hour. So I preferred to focus on some infection. So we'll talk about skin and soft tissue infections, urinary tract infection, and pneumonia. So obviously we have many more common infections, and maybe we can find a time slot to discuss these another day. But I'll focus on this. And the idea is beyond empirical treatment, I really want to share on infections which bacteria I want to treat, and what are their resistance, and why I choose this antibiotic. So you'll see we'll always go from the infection to the bacteria that we want to target, and then to the treatment, so that you can have the whole thinking process of treating common infections. So just to say that, as I'm sure many of you know, the most important difference between bacteria for us clinicians, if it's bacilli, cocci, gram-negative, gram-positive. Okay, it depends on on the configuration of their membrane and the paroi, and then you have this distinction that is very important, because the resistance are not the same at all between gram-positive cocci, between gram-positive bacilli. So next slide. So as you see there, there is this important difference, and maybe we can go to the next slide directly, so that you can see pictures of on the right, upper side of the right. This is a gram-positive cocci. You see, so small, I would say round bacteria that are purple. For example, staphylococci, streptococci, enterococci are gram-positive cocci. You have gram-negative cocci. You know, not many, because there are not many, but it's meningococcus and gonococcus. So Neisseria gonorrhea and Neisseria meningitidis, then STI, sexually transmitted infection, and meningitis. We'll not talk much about them. Then you have gram-positive bacteria, bacilli, gram-positive bacilli, which are not very common, except in some cutaneous infections. And you have gram-negative bacilli. You have purple and in the form of small bacilli. These are, for example, enterobacterales. So enterobacterial bacteria, most of them are gram-negative bacteria, bacilli, and it's very important because their resistance is important. So if we go to the next slide, to the first topic, skin and soft tissue infection. So next slide. So I want to say, first, bacteria that you want to consider with skin and soft tissue infections are streptococci, and specifically Streptococcus pyogenes. Group A, Streptococcus, that's the same. Group A, Streptococcus and Streptococcus pyogenes. And this specific Streptococcus gives cutaneous skin infections and ENT infection, for example, sore throat or cellulitis in the legs or in the arms. So these bacteria, when you want to target it, for the most common skin infection, that is cellulitis. Sometimes it's called erysipelas or cellulitis. It's the basic common infection, next slide, sorry, thank you, that you see most often on the legs in patients with chronic edema or who are obese. Okay, so this infection, you want to target one bacteria is strep A. Okay, next slide, you see other cellulitis. Okay, so you don't see all the cellulitis, but that's the same, that's a big red leg. Okay, strep A is the bacteria you want to target. Next slide. It can also be on the face. Okay, cellulitis of the face, it's the same. So if you have, and we'll talk about atypical situation, but if you have a typical cellulitis, strep A, next slide. And the good thing with Streptococcus pyogenes is that there are no resistance with this beta hemolytic Streptococcus pyogenes, no resistance to beta-lactams. It's always susceptible to amoxicillin. Okay, and it's almost no resistance to gentamicin. But most often, you don't need gentamicin. So the good thing is that you can treat these strep A, so these infections, basic cellulitis, always with amoxicillin. So next slide. So it can be amoxicillin, can be ampicillin, can be penicillin G, depending on where you work on what is available. So penicillin G is IV. So most often you use oral amoxicillin or ampicillin at the dosage that is written here. For a short time, so it's around 6 to 7 days for a simple cellulitis. Okay, so that's the basic guidelines. Some previously, I would say in most guidelines a few years back, the treatment was longer. It was up to 10, 14 days, but it has been shown that 6 to 7 days are enough. And even if the leg, if the face or if the arm is still red, that's mostly inflammation and no more bacteria are present. So you can be very confident in using amoxicillin and not clavulanate, not more complex antibiotics in this case. Next slide. That is very different when you have a cellulitis centered by a wound or by a bite or by a chronic wound or a trauma. That is different. Why? Next slide. Because depending on what is the mechanism of the wound, so these are two photographs are bites. It could be animal bites, cats, dogs. You want to cover other bacteria. Okay, what you want to cover more than strep A, it's anaerobes. So next slide. So you want to target all these anaerobes that you can find in the mouth and that can be transmitted by the bite. So that's when you use and you add a beta-lactamase inhibitor to amoxicillin. So the most common antibiotic that you want to use when the cellulitis is centered by a wound or by a bite is amoxicillin plus clavulanate, amoxiclav, sometimes called. You have, I just put for information other antibiotics that are a good treatment of anaerobes, linezolide, clindamycin, metronidazole, but you won't use them for skin infection. It's for other diseases, maybe for peritonitis, for other diseases where you want to target anaerobic bacteria, but mostly with amoxicillin and clavulanate, it's enough. Next slide. Yes, okay, so amoxicillin clavulanate, it's the dosage is 50 milligram per kilogram twice a day, 3 times a day, and it's maximum 6 grams per day for around 6 to 7 days as the normal cellulitis. It's just that you have a broader spectrum because you want to target anaerobes, and if the patient is allergic, And that's the same for basic cellulitis. You can use doxycycline, which is a good alternative to this amoxicillin clavulanate. Next slide. The other thing, when you treat cellulitis on chronic wound, okay, you don't need to do microbiological sampling. You don't need to sample the wound, and you should not sample the wound. Never do swabs of wounds. That does not work, and that does not show responsible bacteria. So never do swabs of wounds. You want to target another bacteria. So strep A, anaerobes, and the other bacteria that you want to target when it's cellulitis around the wound is, next slide, are staphylococci. Okay, so staphylococci, you know them. They are gram-positive cocci, such as Streptococcus, but they are a bit different. They can colonize the nose and the skin, and they do infection as soon as there are a skin barrier effraction. As soon as the skin is broken by a surgery, by a trauma, by a wound, by a catheter, venous catheter, even peripheric venous catheter, staphylococci can go from the skin to can cause cellulitis or can go to the blood. Okay, so if you have cellulitis on a wound, you want to add to your targets staphylococci. And that takes some explaining. So how should you target staphylococci? Next slide. So staphylococci wild type can be mostly staphylococci aureus. Okay, wild type is susceptible to all beta-lactams and to most antibiotics. So this is an antibiotic susceptibility testing of a wild Staphylococcus aureus. But next slide. The problem is that you will very seldomly see this wild Staphylococcus because most of the Staphylococci aureus have a penicinase. Okay, this penicinase targets penicillin G, J, but also amoxicillin, ampicillin. So it's not a natural resistance; it's an acquired resistance, this penicinase, but that is present in more than 90% of the Staphylococci. Okay, so in most cases, you cannot use in an empirical treatment penicillin G, amoxicillin or ampicillin or Pen-A for staphylococci. You have to use another antibiotic. And next slide. Most of the time, if you want to cover both Streptococcus A and staphylococci, you need to add clavulanate to amoxicillin. Okay, so just to summarize a bit, for common cellulitis without wound, that is erysipelas, big leg, no wound, no bite, no trauma, you can be sure that it's strep A and do amoxicillin. If the cellulitis is around the wound, around the trauma, around a bite, around any skin effraction, you need to add staphylococci and for bites, specifically anaerobes. And that's why you need amoxicillin clavulanate. Okay? But do not forget that most skin infections are basic cellulitis and should be treated with amoxicillin. And that's very important because, as you know, the difference with amoxicillin and clavulanate amoxicillin is, I would say, the vast majority of the microbiota. Because if you do amoxicillin, you preserve the colic microbiota. If you do amoxicillin with clavulanate, you destroy most of the anaerobic bacteria that are colic, okay, that are in the guts. So that's why it's very different to use one or the other. But you should know, because it's highly prevalent, I would say, in many parts of the world, including Ukraine, is that some Staphylococcus aureus are methicillin resistant. What does that mean? Is that they have a new protein in their membrane, that is the MEK-A gene that codes for a specific penicillin binding protein that is not susceptible to any beta-lactams. Okay, so next slide, sorry, thanks. So when you have this MRSA, so next slide, methicillin-resistant Staphylococcus aureus, you have a resistance to all beta-lactams, including penicillin J, oxacillin, amoxicillin clavulanate, cefazolin, including carbapenems. All beta-lactams are targeted, do not work against MRSA. The only exception is, the fifth generation cephalosporins that is not available in most hospitals, but ceftaroline. Ceftaroline is a fifth generation cephalosporin that works on MRSA, but that's not the topic here. What you should remember is that MRSA is resistant to all beta-lactams. So do you want to target MRSA in basic, I would say, skin infections, wound, trauma, on outpatient, ambulatory patients? Most of the time, no. You can go with amoxicillin clavulanate, and you do not target with an empirical treatment MRSA for skin infections. The data that have been shared, and thank you again, regarding MRSA in Ukraine, I found this Jack AMR paper that shows that most staphylococci are sensitive to oxacillin. You need above on the slide 100 among 140. And in the report on antibiotics from Ukraine, you see that you have as much as 40% of MRSA, but that is true for hospital data. Okay, hospital data, maybe you have more MRSA, but for ambulatory patients, outpatients, I would say even in Ukraine, and I'm not aware of many data regarding MRSA in the community, so outside hospitals in Ukraine, maybe you know, but in most countries in the world, you would not target MRSA as an empiric treatment of common skin infections in outpatients. This is different in hospital, but I think when you will talk with Professor Schrauten on severe infection and intensive care, he will talk about treating MRSA in bloodstream infections, in severe intensive care infections. But for common patients, my advice would be, in most cases, not to target MRSA. So amoxicillin clavulanate for cellulitis centering a wound is enough. Okay, the treatment for MRSA, next slide, is, as you know, glycopeptides, so vancomycin or teicoplanin. And you have other options, including daptomycin, linezolide, that I think are available in Ukraine, but should maybe be reserved to specific situations because glycopeptides are the first-line antibiotics. Okay, but do not target MRSA systematically in standard infections for patients that are not severe. Next slide. Thanks. Okay, so a summary of what I said: cellulitis, erysipelas standard, strep A, amoxicillin. Cellulitis on an existing wound, strep A and Staphylococcus aureus, amoxicillin clavulanate. And regarding bites, you need to add anaerobic bacteria to your targets, but it's the same treatment, is amoxicillin clavulanate. Okay, so that is, I would say, basic what I wanted to say on skin infections. Next slide. Obviously, you have many other infections and situations, and I'll show some of them. Next slide. So regarding infection on the fingers, whether it's collected, a small abscess around the extremity of the finger, or more severe infection that goes in the strings of the hand or in the articulation of the hand. Next slide. The treatment obviously will include small surgery, because you have to, when something is collected, you have to explore the collection and get out the pus, because the antibiotics enough only will most often not be enough. And when you have wound in the hand, you know that mostly we advise surgical exploration of whether the infection is deep or not. And so this is mostly surgical, but regarding the antibiotics, is the same as what I said, mostly amoxicillin, clavulanate, but it should be accompanied with surgery. Next slide. And beware of severe skin infections, because when you see a skin infection, you have to look for necrosis. So it's necrotizing fasciitis. So you need to look for purple zones that are purple, that are very painful, that are or patients do not feel these zones of the skin anymore. And so this is severe, and you need mostly to refer to intensive care, surgery. The treatment will be large spectrum antibiotics and surgery. So you should always look out for signs of severity in a skin infection. Okay, so the treatment, next slide, will often be with maybe amoxicillin plus aminoside because the patient is severe, plus something specifically targeting anaerobes or toxinic infection, clindamycin. So you have many combination of antibiotics for severe skin infection, but the mainstay of treatment is surgery. But I think you will maybe talk about this regarding severe infection on ICU. It was only to remember to remind you that you always have to look for severity for skin infections because it can lead to necrotizing infection. Okay, next slide. Regarding urinary tract infection, we will talk about mostly gram-negative bacilli, meaning, next slide, what we call enterobacterial bacteria that are gram-negative bacilli. Just to share a few resistance data on that, because as you know, for UTI, that is specifically what you target. So your treatment is almost integrally depending on the resistance of the gram-negative bacilli when you treat UTI. Enterobacterales, next slide. And the most well-known is E. coli. E. coli wild type is susceptible to anything, to everything, to all beta-lactams. But as you know, sadly, we do not see many E. coli like this anymore. Okay, so next slide. Regarding Klebsiella, even Klebsiella wild type has resistance. I will not detail all the enterobacteria because it will take too much time, but some of them which are the most frequent. But just so you know, Klebsiella pneumoniae, even wild type, has penicillinase and is resistant to amoxicillin, ticarcillin, and piperacillin. Okay, but it's susceptible to the addition of clavulanate. Next slide. Regarding Enterobacter cloacae, wild type, is another Enterobacteria with a natural MC enzyme. It's naturally resistant to amoxicillin and amoxicillin clavulanate. Okay, so this Enterobacter, is naturally resistant and can produce the MC enzyme, which is a cephalosporinase, can be inducted. That's called MC induction. And then Enterobacter cloacae becomes resistant to all beta-lactams up to fourth generation cephalosporins, cefepime. Okay, so this induction is quite frequent and is resistant to third generation cephalosporin, amoxicillin, clavulanate, etc. Okay, so keeping this in mind, next slide. When you have to treat urinary tract infections, you have to consider all these Enterobacteria, Enterobacterales, and the acquired resistance of gram-negative bacilli and Enterobacteria. And the most disturbing resistance, as you know, is ESBL. And a very important question for people treating UTI as an empirical treatment is what is the prevalence of ESBL in Enterobacteria in my context. And that will highly modify empiric treatment of urinary tract infections. The other thing is which urinary tract infection I want to treat. And so the treatment will depend obviously on resistance, but also on the kind of infection you want to treat. Cystitis is a common infection with no fever. You might want to treat pyelonephritis or prostatitis. It's fever with urinary symptoms. And then you have the severe urinary tract infections with sepsis, septic shock, or an obstruction that would require urological surgery. Okay, next slide. So depending on the infection and the level of resistance, and the level of resistance, you have some data in Ukraine, and thank you again for sharing. For Escherichia coli, in a pediatric hospital, they had around 65% of isolates susceptible to third-generation cephalosporin. So that means 30% of ESBL in a pediatric hospital. And for Klebsiella pneumoniae, it was even more. It was around 75% of isolates that were resistant to third-generation cephalosporins, and only 60% susceptible to meropenem. So highly preoccupying situation. Regarding what I found in your report in Ukraine, the level of resistance to third-generation E. coli is also very high, so it confirms the data from the first article. It's 50% in E. coli and 85% in Klebsiella. Again, that is hospital-based data. And we know that hospital-based data is way worse than outpatient community data. So keeping this in mind, I think it's not a common guideline that you have to apply, but I would think that for common infections that are not severe, you can not always target ESBL. Next slide. Because obviously, you cannot target ESBL in all outpatient community-based UTI. So regarding cystitis, it's very easy because I would say you have options that works on ESBL and that are validated for cystitis. Oral fosfomycin, 1 dose. It does not work on Klebsiella, but most of the cystitis are E. coli. Bon. And another option is nitrofurantoin. And it's in your guidelines, I think. It's 5 days of nitro for the treatment of cystitis. So cystitis is okay. Pyelonephritis is more difficult because the main question is, do I want to target ESBL or not? If you want to target ESBL, you have to treat with carbapenems. And that's not an option for everybody. So in pyelonephritis that are not severe, the guidelines around the world are to give third-generation cephalosporins, or in some guidelines, quinolones, if you cannot give IV treatment. So most of the time, you can try a probabilistic treatment, empiric treatment with third-generation cephalosporin or quinolones. Obviously, if the patient is severe, at the end, you have to target ESBL, because you cannot let a severe patient with sepsis or septic shock in a context in Ukraine where almost 50% of gram-negative bacilli are resistant to cephalosporins, to third-generation cephalosporins. You need, I think, to target with carbapenems and aminosides. But you need severity to do this. Regarding prostatitis, most of the time, the empiric therapy in most guidelines would be based on quinolones or Bactrim. It's sulfamethoxazole, trimethoprim. Okay, and in UTI is different from skin infections. You need to do microbiological sampling. You need to do cultures, because then you will be able to adapt. Okay, so for infections that are not severe, you can give, I would say, a standard treatment, and then if you see that it's an ESBL, you have some time to adapt and treat ESBL, adapted to the antibiotic susceptibility testing. For severe infections, you have to begin broad spectrum, then you see urine cultures, and you can maybe reduce the spectrum and do a narrower spectrum according to the antibiotic susceptibility testing. Another thing that is not directly related to empirical therapy, but next slide. We've done some flyers with that. As you know, everywhere in the world, a lot of urine cultures are done when they are not needed. And people are treating urine cultures that is related to a colonization, okay, not an infection. And this increases resistance. So this increases ESBL. And the day you need antibiotics for a real infection, it does not work. So I think we should all try to reduce the use of unnecessary urine cultures, and most urine cultures for only smelling urine or cloudy urine they are not needed and they are not recommended on urine cultures on vesicle and bladder catheters are not needed if the patient has no fever, do not complain of pain around the catheter or pain when urinating. So you should do urine cultures when you have a clinical diagnosis of infection. That's very important because then it's the only case where you treat patients. Okay, there are some exceptions. Okay, in pregnant women, you can do urine cultures without infection or before urological surgery, but these are exceptions. Most of the time, no symptoms, no fever, no urine cultures. Okay. So the treatment duration, as you know, has been a lot reduced regarding the different infections. With cystitis, if possible, is a single dose, one-shot treatment with fosfomycin oral. It can be a few days with nitrofurantoin. For uncomplicated pyelonephritis, okay, it's most of the time 7 days. Okay, this has been validated by a different randomized trial. And for severe pyelonephritis, where you want to begin with a broad spectrum and then according to the culture, to the susceptibility testing, you try to narrow the spectrum, it will be 10 days. Okay, regarding male infections, prostatitis stays at 14 days. Okay, it's one of the infections. Sorry, yeah, next slide, I forgot. So this is what I was saying. Regarding prostatitis, it's 14 days. Regarding acute pyelonephritis in men, is 10 days. And you have some male cystitis, afebrile urinary tract infection. So it means men with symptoms of cystitis without fever, so without prostatitis, and it's accepted to do a short duration treatment of 7 days. Excuse me, just 1 second, I close the door. Okay, sorry, I had some noise, so I closed the door. Okay, so next slide. So the third topic is community-acquired pneumonia. Please stay with me a few more minutes about pneumonia, which are quite frequent. Next slide. So we'll describe again the bacteria that you want to cover, and it depends on the situation. Okay, if you have community-acquired pneumonia in a young adult, I would say young below 65, without specific chronic disease, specific lung disease, no transplantation, not immunocompromised, with no severity, you have to focus on one bacteria that is more prevalent in this case. Next slide. Is another Streptococcus pneumoniae. Okay, as you know, Streptococcus pneumoniae can be carried, is a carriage in the ENT region, and then from carriage, it can go to different infections, to ENT infection, otitis, sinusitis, but it also can cause pneumonia. Okay, pneumonia linked to Streptococcus pneumoniae are very severe. Okay, severe pneumonia. Next slide. And next slide. So I did not find data in Ukraine regarding resistance to pneumococci, but what you have to know is that most pneumococci are very susceptible to amoxicillin, but sadly, the pneumococci can merge some proteins binding penicillins with oral streptococci. And then the susceptibility to amoxicillin is decreased. So these are some French data, but as you know, the case in many countries, as much as 30% to sometimes 60% of the pneumococci have a lower susceptibility to amoxicillin. That does not mean amoxicillin does not work. That means we have to follow this resistance and to use adequate dosage of amoxicillin. Okay, but not much clinical, I would say, resistance to amoxicillin. So in most cases, next slide, in a young adult standard pneumonia, I would say we focus on pneumococcus, okay, and the treatment is amoxicillin. And that works in most cases, even if we have pneumococci that are a bit less susceptible to amoxicillin. Okay, so this resistance is not clinically important in most cases. If the patient is allergic, you can use in some guidelines pristinamycin. In other guidelines, you can use quinolones. And if you have no improvement after 48 hours, it means can be an atypical pneumonia with intracellular bacteria, and it is recommended to switch to pristinamycin or to another macrolide. Can be azithromycin, can be jodamycin, so mycin. A lot of macrolides can be used, so this is pristinamycin. I don't know if you have it, but another macrolide would do the job. Next slide. In young adults with features suggesting intracellular bacteria, pneumonia with intracellular bacteria. What does that mean? It's pneumonia with gradual onset, with extrapulmonary symptoms, with a pattern on chest X-ray that is interstitial, not alveolar. And maybe you've seen in 2024, there was a huge epidemic outbreak of Mycoplasma pneumonia. Usually, you don't have much inflammation in the blood. So next slide. So I've not found data in Ukraine, but most of the world have seen this outbreak of Mycoplasma pneumoniae. So these are US data. And you see every year we had some Mycoplasma pneumoniae. In 2024, we had a large outbreak. And so these microorganisms, these bacteria, are not susceptible to amoxicillin, the intracellular bacteria. Mycoplasma, Legionella pneumophila, Legionellosis, chlamydia, they are not susceptible to amoxicillin. So you need, next slide, to use a specific antibiotic that works on intracellular bacteria. So it's pristinamycin or azithromycin, so macrolide antibiotic, okay? But only for patients with these signs, okay? Not for all pneumonia. Next slide. Next slide is pneumonia in older adults, above 65 or with chronic disease, immunocompromised, lung disease, heart failure. So patients with some, I would say, heavy medical history or a bit older. Next slide. You won't limit to only pneumococcus in most guidelines, because you will want to target other bacteria that can lead to pneumonia, especially Haemophilus influenzae, that has some resistance to amoxicillin. So it's a case where you usually don't use amoxicillin as a standard therapy because of Haemophilus influenzae resistance to amoxicillin. So people use either amoxicillin clavulanate or third-generation cephalosporins that also allows to target enterobacteria. Okay, so I would say in standard bacteria, young patients, no specific conditions, you can go with amoxicillin. With pneumonia with gradual onset, interstitial pneumonia, low inflammation, you want to go to a macrolide. And I would say in patients that are either old, elderly patients or with chronic conditions, you might want to go to amoxicillin clavulanate, or if the patient is hospitalized, third-generation cephalosporins. Obviously, that's for patients that are not severe, okay? And for next slide. So that's what I was saying. Okay, I think you can go to next slide because I just said that. Regarding the duration, I want to share the French guidelines that are, in my knowledge, the last guidelines published on pneumonia, because we've done a huge literature work to decrease the duration of treatment for pneumonia. And what we say in France, and that's open to discussion because it might be different, is that you can do 3 days treatment for pneumonia as long as you have these stability signs, I would say. In fact, if I want to summarize, if a patient is treated and is better, you can stop at 3 days. If a patient is better at 5 days, you can stop at 5 days. And in all other cases, you can stop at 7 days. So it's a bit radical, this position, but interesting because it decreases the duration of therapy. But the main message, everybody accepts that, but not only French guidelines, is that maximum 7 days for pneumonia, even in intensive care. The only exceptions are abscess, pleural infection, pleuresia, purulent pleuresia, abscess. These might need more than 7 days. But any pneumonia, 7 days max, and even you can go to 3 days, and most pneumonia we see are 3 days right now. Regarding severe pneumonia, next slide. You will talk maybe with Prof. Schouten of severe pneumonia, but next slide. One thing you want to consider with severe pneumonia is Legionella pneumophila, is legionellosis. It is a cause of severe pneumonia alongside pneumococci. So you need to use and to add to your treatment both the treatment of pneumococcus pneumonia and legionellosis when the pneumonia is severe. So in most cases, next slide, we treat with amoxicillin or third generation cephalosporin and a macrolide, as long as we don't get the microbiological samples for legionellosis. So it depends, maybe depending on the country, it's not always with the addition of a macrolide, but I would say a lot of countries recommend this for severe, that means for intensive care unit pneumonia. Next slide. Another message that is very important for us as antimicrobial stewardship specialists is that you don't need antibiotics for viral pneumonia, and they are almost never super infected. So maybe as you've seen many COVID patients, I would say in the hundreds of COVID patients I've seen, super infection was very rare, but a lot of patients receive antibiotics because they had pneumonia, viral pneumonia, and people were afraid of super infection. Most of the case, you don't have this super infection, so you should not add antibiotics. And the other thing is that you don't need antibiotics for bronchitis or only upper respiratory tract infections with no pneumonia, no clinical signs of pneumonia, no chest X-ray of pneumonia. So it's okay not to treat with antibiotics, except in severe COPD patients where the lung disease specialists, but even the ID specialists recommend a short course of amoxicillin clavulanate to cover pneumococci, Haemophilus influenza, enterobacteria. Okay?
Sorry, have you finished?
I think there was a challenge with the speaker's connection.
Sorry.
Почаємося з невеличкий технічний збій.
I
Зараз ми
had a-
продовжуємо.
Yeah, sorry for some technical issues. We
Okay.
can continue, thank you.
Okay, thank you. Sorry, I was disconnected. The previous slide, you heard me? This was okay?
Yes,
Or okay.
yes, it was fine.
Perfect. Next slide. So a few golden rules. But in case of severity, sepsis or septic shock, and you will discuss this in a specific webinar, obviously you should begin antibiotic urgently and with a combination of broad spectrum antibiotic. But for most common and non-severe infections, whether in outpatients or inpatients, it's not always necessary to take all resistance into account. Okay, you should target the most frequent and susceptible microorganisms, bacteria, because you have some time to see what happens, and for UTI to get the culture, for skin disease to see how the patient clinically respond to therapy. Okay, empiric therapy must take into account whether the infection is community acquired or nosocomial, and any history of previous infection or known carriage of multi-drug resistant bacteria. It should take into account the country and local epidemiology, as we discussed a bit, and previous antibiotic recent use. Okay, but the message is that do not always try to cover every resistance for empiric therapy in non-severe patients. The other message, as I said, that if you've done microbiological samples, mostly for UTI, in what we discussed today, because you don't do microbiological samples in skin infections, and in most pneumonia, you don't do microbiological samples, you should consider clinical progress and the results of the sample and the culture to try to reduce the spectrum of treatment. Fourth rule, an antibiotic course longer than 7 days is very rarely justified. Okay, pneumonia maximum 7 days, skin infection 7 days, except for severity. But for pneumonia, all pneumonia are 7 days, and then for UTI, most UTI are 7 days, except prostatitis or severe pyelonephritis. Okay, and another message that is very important: do not treat colonizations. Do not sample urine in patients with no clinical infection. Do not treat colonization. Okay, thank you. Next slide, but what we might discuss another time, but we won't have time to discuss this. And I'm really happy to take any question, any remarks. If you want to share a specific expertise or to comment what I said, you can have different opinions or practices. I'm very happy to take questions and discuss.
Дуже дякую за вашу лекцію, професоре Peiffer-Smadja.
Thank you very much for your lecture. Very interesting and useful material, useful both in inpatient and outpatient settings. And I'm sure it will be very useful for our participants. We have already several questions. Colleagues, please don't be shy. Write your questions in the chat box, and within the time available, we will try to answer them. I see the following question. So I think the colleague just commented on the slide in the beginning of the presentation. So it was about infected chronic wounds. And the question is, why is it not necessary to conduct microbiological tests on infected chronic wounds?
Okay, so on chronic wounds that are infected, it's not that you never do samples. First thing is that swabs, so only swab samples, is not good because it does not reflect the bacteria that are causing the infection. And we know it very well. It reflects the flora that is on the wound, but not the causative bacteria. So you should not do swabs because it's misleading. But if you have, and that must happen a lot, I think, in Ukraine, if you have following trauma or wound, deep infection with a bone infection, for example, osteitis, or a very complex infection after surgery, you should do samples because you need to guide therapy. But you should do adequate samples, meaning biopsy. You should ask surgeon or people who can do to do deep tissue sampling. So you cut some tissue, some skin tissue, or you go to the bone to do a biopsy, and this will reflect causative bacteria, but not the swab. And this is very important to conduct treatment because then you have on these infections often a very long therapy. I did not talk about post-surgical infection, but you can have 6 weeks to 3 months antibiotic therapy. So you need samples and you need culture, but not swabs. They are really misleading.
Дуже дякую за вашу відповідь. Хотілося б
Thank you very much for your reply. And I'd like just to make it clear to the participants that it's important to differentiate the infections at the primary care level, where there are some protocols, and at the specialized secondary or tertiary level. And as Professor said, when we speak about non-sterile locations such as a wound, we need to differentiate clearly whether it's a colonization or it's an infection process which causes systemic reaction. And based on that, we decide what to do with that. Thank you. And the next question is about bacteriological studies in case of soft tissue infections. Do you use these swab cultures from the surface routinely or not? And if yes, then how often and in which cases? Wounds, bites, etc.
Thank you for the question. And it joins what I just said. We never swab wounds. We never do. And even if we do, the microbiology lab, they take the swab and they put it in the bin. So we never swab wounds. And that's not only our hospital. That's we discussed during SGAP with many colleagues around the world. Swabs are a bad reflection of the infection. They, as my colleague says they show the colonization of the wound, the colonization of the skin, and even if it's infected, they will not show the bacteria that is the cause of infection. So that's why if you have simple infection, you do not sample, okay? You treat empiric therapy as discussed, depending if it's on a wound, you want to treat strep A and staphylococci. If it bites, you add anaerobes, so it would be amoxicillin clavulanate. And if it's a very complex infection and you need samples in specialized care, you go to deep sample, not swab surface.
Thank you
very much, Professor, on highlighting this important thing. And I would like also to remind our listeners that recently we had an interesting webinar dedicated to wound sampling. It's extremely important to also mention that swab is not very informative. And it's required to clean the wound first and take the deep sample. And the next question is, do you take biological material in case of fresh wounds and animal bites?
That's a good question. In most cases, no. The question with animal bites is depending on where it is. And if you think, especially on the hand, if you think it went to noble tissue, the surgical exploration is important. And in this case, they will do some samples. But in most bites, where you see that it does not go to deep tissue or to bone, or we don't sample. And in fresh wounds, even in complex trauma, we usually don't sample. We treat empirically with amox clavulanate, and if the clinical evolution is good, we stop there. But when you do surgery, because it's a very complex wound, or because it's needed, because it's a severe trauma, if the surgeon see deep infection, because the wound may have lasted a few days before management, you will sample. But I would say in simple case, no sampling. In surgical needing case, you do sample if the surgeon sees an infection.
Thank you very much for your reply. The next question maybe is a little bit out of topic for today, but the question is, which drugs should be preferred in gynecological practice for treatment of chronic salpingitis or metritis?
Well, that's an interesting question. Again, the question that I always ask myself in any infection is, what are the bacteria you want to target? So regarding salpingitis, some enterobacteria, okay, because it can go from the vagina to the gynecological tract as UTI, so enterobacteria. You need to target, in most cases, intracellular bacteria. This can be salpingitis related to Mycoplasma, chlamydia. Okay, and you need to target anaerobic bacteria, because that's bacteria you can find in salpingitis. Okay, so taking these into account, You can choose depending on your local resistance, but you need most often a macrolide for the intracellular bacteria. So it can be doxycycline, can be azithromycin. You need either a third generation cephalosporin plus metronidazole to do the anaerobic infection and enterobacteria, or some teams, some countries would use amoxicillin clavulanate because it covers some enterobacteria and anaerobic bacteria, but is less powerful against enterobacteria, as was discussed, because it does not work in Enterobacter cloacae. It does not work in a lot of enterobacteria that have penicillinase. So most teams would do doxycycline or azithromycin, third generation cephalosporin, and metronidazole.
Дякую за вашу відповідь. Наступне питання.
Thank you very much. The next question is, what would be your actions when Candida fungi are detected in a wound in a diabetic foot? Will you prescribe antifungal drugs?
That's an interesting question. And again, it goes to the quality of samples. You should never treat what you find on poor quality samples. Meaning if you swab a diabetic wound, a diabetic foot, if you swab, you'll find many things. Most of them are not related to the infection. You will find a lot of bacteria, you will find the candida, but so we don't consider fungi on these poor quality samples. But if you do a biopsy of the bone in diabetic foot, in the biopsy, you find fungi, you'll obviously treat them. But in my experience, in most good and quality samples, you don't find fungi in diabetic foot infections, or it's not frequent.
Дуже дякую, дуже інформативно. І враховуючи, що у нас
Thank you very much indeed, and it's very rich in information content. And bearing in mind that we've run out of time, so the final last two questions, and we'll be closing out the session for this afternoon then. So the next question up, whether the Enterococci faecium and fecalis evoke pneumonia, cause pneumonia?
Enterococci?
Enterococci faecium and fecalis, can they cause pneumonia?
Really, it's not frequent. It's not frequent at all. What we usually treat when we usually see enterococci is bloodstream infections coming either from colic, for example, colic cancer, or from catheter. And though enterococci can go from the catheter to the blood and do endocarditis. But frankly, we don't see often pneumonia with enterococci. So maybe in some post-surgical, very specific situation, but it's not frequent at all. So it would not change my empiric therapy of pneumonia. So I would keep amoxicillin for standard, amoxicillin clavulanate for specific situation, and macrolides for mycoplasma, clinically evocating mycoplasma pneumoniae.
Дякую за вашу відповідь. Знову ж таки,
Thank you for your answer. And also bearing in mind all the forthcoming questions coming in and all of the other questions. So it's very important to say that in the inpatient healthcare facilities and the clinical facilities, so you should do microbiological assay up to a very high standard and cumulative data and antibiotic-grams. And I think this will prove the best indicator, and you will better understand which microorganisms being prevalent in disease areas, loci, and you will see their susceptibility profile that may significantly vary. That will prove the specifics of your health facility. Last but not least, questions. So two questions to ask once again. I will ask this question here again. That is more interesting. So for which is the empiric therapy advised for the infected bed ulcers, pressure injury?
Excuse me, say again regarding which
pressure injury. So which empiric therapy advised to treat infected pressure injury or bed ulcer?
Okay, thanks. Pressure. Yeah, you're right. So my first point is that in most cases, when people call me for bed ulcers that they think infected, is not infected. It's like only regarding to wound dressing. It's only a bit inflammatory, and you have some pus maybe, but it's not deeply infected, and you don't need antibiotics. When you need antibiotics, is rare, but is when the bone is infected, when there is osteitis below the bed ulcer. And so it's very difficult to treat empirically because it could be a lot of different bacteria. And it could be resistant bacteria because often these patients have been hospitalized a long time. So what you need for this is never to treat empirically, except in septic shock, and you do broad spectrum. But if there are no septic shock, you need a bone biopsy, as for diabetic foot, and you need then to treat what you find in the bone. Most often, you are not in an urgency to treat. Okay, so voilà, beware. It's not often infected. When it's infected, it's because of osteitis, and you need bone biopsy to guide therapy. So I would say no empirical therapy in most cases.
Дякую за таке
Thank you.
уточнення.
Thank you very much for clarification. I am in agreement. Sometimes empirical treatment is very hard to focus, and you should focus on your targets. It's based on the microbiological assay result. So we've exhausted our time this afternoon, dear colleagues and participants. And once again, thank you very much indeed. So for our colleagues and our esteemed colleagues from the CDC USA, Columbian University there as well, and also the ASMET Society, and of course to the Professor Nathan Peiffer-Smadja for his lecture, very much rich in content. Thanks very much for taking the questions and giving the answers. So, and the recording of this lecture shall be soon uploaded to the UPSC-based website containing all of the other materials, uploads, and I'm just calling out to users to check it out and to listen to it and the announcement of all the forthcoming lectures and webinars in conjunction with the other expert speakers and ICAP partners will soon be up on the UPSC website, so stay tuned so as not to miss it out. So we'll make sure that we timely invite everyone in. So enjoy the rest of your day and peaceful sky over you.
Дякую.